So good afternoon, everybody. We'll be trying to be short, no financial interest involved. So the first described by Knapp in 1869, and modern concept of the macular hole and classification given by gas. And prevalence varies from 3.3% in Baltimore study to 1.7%, and in bilateral cases up to 11.1% we can find. And first successfully operated by Kelly and Wendell and reported in 1991. So there are a few dyes we use for macular hole surgeries like triamcinolone, indocyanine green, tyrpin blue, and brilliant blue. And there are some adjuvants also like autologous serum, tissue adhesives, transforming growth factor beta 2 and thrombin. And instruments, there are lots of instruments nowadays we use like ILM forceps, then diamond dusted scraper, then Sewell loops, that is Fennis loop, and PIC, and even PFCL also in some cases that we will see. So the case one, the difficulty is like this child of 8 years old and post-retinal detachment surgery, large size of the hole and the retina was unstable. Here we can see there is a giant retinal tear operated with silicon oil, and after that we got a full thickness macular hole. And we stained it with brilliant blue dye, and we peeled the epithelial membrane, and then we started to peel the ILM. Due to the large size, there is already some SRF in the posterior pole, and you can see that it is not enough stable. So, and this ERMs are attached with the arcade vessels also. So, here after first we peeled the epithelial membrane, and then you can see we put the PFCL because the ILM is not completely peeled off, which stabilizes the retina, and then we peeled up with the end grasping forceps, then which we can see you can do it completely. And then we did the fluid exchange, getting the last few drops from the macular hole itself, and injected C3 with gas. And we can see this is a 2 weeks post-operative nicely closed macular hole. And the case 2 is a diabetic patient with old branch retinal vein obstruction with epithelial membrane. And there is laser scars near fovea causing adhesion of epithelial membrane and ILM. And here we can see it. The PVD is not complete also. And we did a 27 gauge vitrectomy. And we induced the posterior vitreous detachment with the tricot. And then we used that loop because first we tried with the ILM forceps, and we saw that there are plenty of epithelial membrane already which stained with the triamcinolone particles. And then we peeled from all around, and we used it as a reverse flap technique and peeled it up from all sides. And few of the areas are not coming with the loop, so we used the end grasping forceps also. And we trimmed it with the cutter with the low vacuum and high cut rate. And this is a nice technique, you don't have to do anything, just trim it and do fluid exchange and put the gas stamp on it. We usually tell the patient to keep the head down for 3 days as much as possible, because when we fill it up with perfluoropropan, you don't have to be that much strict with the head down position. And never ever go to the macular hole in this type of cases because the flap will be lost otherwise. You can see nicely closed hole. And this is a high myopia case with the staphyloma, and there is a vitreous schisis also and the retinal schisis, which we can see here. There's a long axial lens itself causes problem. And then we stained with the brilliant blue dye. And when we are peeling it up, we realized that it was the posterior vitreous in fact, and it is not the ILM. So first we peeled it, see it is below the PFCL in fact. First we peeled the posterior vitreous, and after that we were able to reach to the ILM, and then we peeled it. And this is a traumatic macular hole with extensive scarring of retina and long duration of 2 years. And as we will be able to see, this is the situation, and you can see the papillomacular bundle area totally scarred with that full thickness hole. And here we could not get it up anything with the engrasping forceps, so we used the loop with very good effect. And it is literally only the 50% of the area we can peel the ILM, the other area it is out of question. And here also in this type of case even, it is really worthwhile to try. In fact, seeing that you may not try that, okay, it is gone, but as we saw astonishingly, it gave good result. And only this half you can do anything, but the other half is gone totally. And definitely we trim it. We don't try to keep the ILM including how many percentages you are going to keep. See, nothing is coming out from that scarred area because it is totally adherent. So this part only we can harvest. And we did a fluid exchange and put gas tamponade. And after that you will be able to see the result. See, the macular hole is closed, and you can see the OCT also. Yeah. So this part is this is the V-shaped closure, but it is closed, and the vision improved also by 2 lines only. That is, I thought that is enough for this case. Thanks.